Welcome back again in the video discussion of another class, that is physiology and pathophysiology of hypoxia and hypercarbia in obstructive airway disease, COPD and bronchial asthma, and principles of oxygen therapy in the hospital and home. So, in this brief discussion we will try to understand the basics of hypoxia and hypercarbia and obstructive airway disease, and what are the principles of oxygen therapy that we use in the hospital and in the sometime for the patient who are prescribed on the home oxygen therapy. So, let us begin. And so, the larger objective for our today discussion will be to understand the pathophysiology of hypoxia and obstructive airway disease, that is bronchial asthma and COPD, pathophysiology of hypercarbia in OAD, for example COPD and bronchial asthma. What is the cause that they try to retain the carbon dioxide, and principle of oxygen therapy in the hospitals with some indications also in medical conditions, and principle of oxygen therapy at home. There are certain set of patients that are prescribed on the home oxygen therapy. So, we will try to discuss, we will try to understand that how to prescribe and what are the patients that will need home oxygen therapy. So, before going to that, let us just do some exercise and we should try to understand that how much air do we breathe in a day. So, it is very surprising that is it the number counts to this so much air, that is 11,000 liters per day air we breathe, and this is almost equal to a normal size swimming pool. This much here we can see. So, there is a lot of air we breathe in a day. Okay. Out of that breathed air, how much oxygen do we consume in a day? If you calculate this one, so it comes around, that is 5% of inspired air, that is 5% of 11,000 liters or 550 liters of oxygen per day we consume on a daily basis. So, this is so much amount of 550 liters of oxygen we consume, and that is provided to us free by the nature. So, having understood this, let us come to the hypoxia. So, what is hypoxia? Hypoxia is simply a condition that causes deficiency in the amount of oxygen reaching the tissue. Means the tissue is not able to have enough oxygen supply. So, this is simply a condition called hypoxia. There is a deficiency in the amount of oxygen reaching to the tissue. So, we know that hypoxia is a state in which oxygen is not available in the sufficient amount that is required for a normal metabolizing tissue to maintain the adequate homeostasis and the metabolic function. So, this is your hypoxia. Now, this can be due to the inadequate oxygen delivery to the tissue, that may be due to if there is a blood supply is low or there is a low oxygen content in the blood, that is called hypoxemia. So, hypoxemia is a quantitative measurement. If our blood has a low oxygen content, then obviously the tissue will suffer hypoxia, because there is already low oxygen is there in the systemic circulation. So, hypoxemia can cause hypoxia, but hypoxia can be also due to low blood supply. Fine. So, now what is the effect of hypoxia? Hypoxia can vary in the intensity from mild to severe and can present in the acute or chronic forms, and the response to hypoxia is variable. While some tissue can tolerate some forms of hypoxia, ischemia for a longer duration, other tissue are severely damaged by the low oxygen level, because our body has a different sensitivity for hypoxia. So, if we know that what is the tolerance of hypoxia to the various tissue, the brain, CNS, central nervous system is a very much sensitive to hypoxia, and the survival time is less than 3 minutes. However, here you can see hair and nail, they can survive for several days. Kidney and liver, they can survive 15 to 20 minutes, skeletal muscles 60 to 90 minutes, vascular muscles 24 to 72 hours. So, what does it mean? The tolerance to hypoxia is very less, and survival time is less than 3 minutes in case of brain. So, any patient who is coming to us in emergency or clinical condition, when we see that the patient is having hypoxia, we can say that patient is hypoxemic, there is a low oxygen saturation, we should take a immediate action to improve hypoxia. Otherwise, the patient can have a permanent brain damage. Alright. So, this is very important to know the effect of hypoxia while treating the patient in emergency or in the wards. So, coming to the etiology. So, what could be the etiology for hypoxia? There may be, that you have just discussed, there may be low blood flow to the tissue or there may be low oxygen content in the blood. So that is called hypoxemia. So in order to understand the mechanism of hypoxia, we should know in the order how the oxygen is carried by hemoglobin, direct interactions between the red blood cells in the pulmonary capillaries and the air in the alveoli. We should know the route, we should know the path which oxygen follows from lungs to the tissue to understand the mechanism behind hypoxia. So for that, we know this is a diagram that we take oxygen goes in the lungs, and from the lungs this is deoxygenated blood gets oxygenated, and heart pumps the oxygenated blood through arteries to the organs, and deoxygenated blood comes to the heart and it gets oxygenated. So this is the process by which oxygen is taken and you can see CO2 is washed out. Alright. So this process can be compromised at any one of the following 3 points, that is airflow to the alveoli, that is ventilation, if less air is coming, or maybe the problem in the airflow to the lungs, or there may be blood flow to the lungs, that is perfusion. If the blood flow is not enough by the heart, that can also cause hypoxia. And if everything is all right, for example airflow is okay at the lungs level, blood flow to the lungs is also fine, but there may be gas exchange through the interstitial tissue, that is diffusion across this capillary membrane. That diffusion occurs in the alveolar capillary membrane. So in that situation, if the membrane is thickened or there is some barrier in the diffusion of the oxygen, that will also contribute, that will also cause hypoxia. So these all 3 levels can cause hypoxia. So let's understand one by one the mechanism of hypoxia. So what will be? Number 1 will be reduced oxygen tension, that is less oxygen in the air. Second will be hypoventilation. Third will be ventilation-perfusion mismatch. Fourth will be right to left shunt, and 5 will be impaired diffusion of oxygen. So these are the 5 important points that cause, that is the mechanism of hypoxia. Let's understand one by one. So that is, one is reduced oxygen tension. This is very important. It happens in case of high altitude. For example, if you go in the mountain or the hilly area on the top, there you can see there is a less oxygen in the inspired air and ultimately causing to hypoxia because the oxygen is less in the atmospheric air that we are breathing in. So this will cause a hypoxia. Second is your hypoventilation. What does it mean? Hypoventilation means breathing that is too shallow or too slow to meet the need of the body. If someone is breathing very slow or too shallow, that is not enough oxygen, enough ventilation to meet the daily demands of the body, that will also cause hypoxia, and this process is called hypoventilation. For example, look, this gentleman, this is sleeping and is not able to take a proper deep breath. This can be due to CNS disease, there may be decreased central respiratory drive, respiratory disorders, there may be restrictive chest physiology, pulmonary hypertension, hypoxemia, hypercapnia, there may be airways problem, potential difficult airway, there may be cardiovascular problem, coronary disease. So these are all the diseases that can cause hypoventilation. Okay. So what happens in hypoventilation? That may be, in hypoventilation, this can be due to airway obstruction, that can be proximal as in case of laryngeal edema or a foreign body inhalation, or it can be distal as in the bronchial asthma or in the COPD. There may be impaired respiratory drive as in case of deep sedation or coma. For example, if somebody is sleeping, so he takes a very small and shallow breathing sometimes. So that is because there is a CNS is depressed or CNS is sleeping in that situation, so it will have a impaired respiratory drive. If the patient is having restricted movement of the chest wall, like in obesity hypoventilation syndrome or circumferential burn, massive ascites or encouraging spondylitis, that will also cause hyperventilation. And we all know that in a neuromuscular disease like myasthenia gravis, muscular dystrophy, amyotrophic lateral sclerosis and frank nerve injury, the patient will not able to take a proper breath and will cause hypoventilation. Now, another important mechanism is your ventilation-perfusion mismatch. This is one of the very important mechanism contributing to hypoxia, especially in the obstructive airway disease patient in COPD and bronchial asthma. So let's try to understand what is VQ mismatch. Before that, we should do some calculation. That is, first is alveolar ventilation. Alveolar ventilation is the amount of air that is taking part in the gas exchange per minute. So if we calculate respiratory rate multiplied by tidal volume minus dead space volume, because this amount of air is not available for the gas exchange. All right, we know that tidal volume is 500 ml and dead space volume is 150 ml. So if we reduce it and if we calculate, it will come around 4900 ml or 5 liter approximate. Okay. So, this is the alveolar ventilation per minute. Now, let us calculate how much blood goes to the lungs. That is almost 100% of cardiac output goes to the lungs for oxygenation. So, if you calculate cardiac output, that is heart rate multiplied by stroke volume, that is volume ejected in each beat. So, it is approximately around 70 to 80 ml per ml and heart rate is 72. So, if we can calculate this one, so we will find that it is also 5 liter. Here you can see. So, this is, what does it mean? If you look here, this 5 liter and this is matched. So, minute ventilation, if you see, is equal to your cardiac output or rather alveolar ventilation to be specific. So, VQ ratio is 1 in normal condition. It means almost 5 liter of blood gets oxygenated per minute. So, what happens in VQ mismatch? In ventilation perfusion mismatch, here you can see if this alveoli is well ventilated, but there is no perfusion. So, there will be no perfusion, I mean no blood is going to that part. So, this will be VQ mismatch. Another, it is well ventilated and well perfused. So, here VQ ventilation perfusion will be matching. The blood coming to this part of alveoli will be matched and CO2 will be washed out and oxygen will be taken in, but not in case of here. So, here blood will, there is no perfusion. So, blood will not be oxygenated ultimately and all the deoxygenated blood will be circulating through systemic circulation. Here we can see this alveoli is poor ventilated. For example, if there is an infection or this alveoli is filled with pus or some infective process. So, this alveoli will not be available for gaseous exchange and ultimately leading to your ventilation perfusion mismatch. Also, if you can see, if this alveoli or if this alveoli is poorly perfused because of some disease condition, the sluggish, there is flow is slow, flow is sluggish, in that situation also there will be VQ mismatch. Clear? So, these are the conditions where there will be ventilation perfusion mismatch, but on the right hand side here you can see this is well ventilated and well perfused. So, here the ratio will be ventilation perfusion will be almost equal because the blood is coming to this part is well ventilated because this alveoli is working fine. Alright. So, this is how ventilation perfusion mismatch happens. So, we can see here that ventilation perfusion mismatch happens because of the disease in the alveoli or could be disease in the circulatory system. So, obviously, and ventilation perfusion mismatch is a pathological condition in the most of the cases. It does not happen normally. Normally, this is the situation here. There will be well ventilated alveoli and well perfused lungs tissue. So, in that situation, this is the physiological part, but this VQ mismatch is pathological condition. So, what could be the cause of VQ mismatch? The decreased VQ mismatch will be if there is impaired ventilation or high perfusion. That happens in chronic bronchitis, obstructive airway disease, mucus plug, pulmonary edema. So, what happens here? It impairs the ventilation and therefore decrease the ratio of ventilation to perfusion, because perfusion is all right, but there is no air is coming because there is a chronic bronchitis, there is a bronchospasm. So, air is not coming in. So, in that situation there will be decreased VQ ratio because ventilation will be decreased, but perfusion is well maintained. So, in that situation this ratio will be decreased. And what will happen in case of increased VQ ratio? There will be impaired diffusion, impaired perfusion actually, that happens in the pulmonary embolism because there is a higher ventilation in comparison to the perfusion leading to the VQ ratio. Ventilation is okay, but perfusion is 0. There is no perfusion because of the large embolus is obstructing the flow of the blood to the lungs. In that situation, there will be increased VQ ratio. Now, another is your right to left shunt. What happens? Normally, the blood crosses from the right to the left side of heart without being oxygenated, and the cause include what happens if there is a defect, like if there is anatomical shunt. Here we can see this is anatomical shunt. Because of this shunt, the blood bypass the alveoli and intracardiac shunt, ASD, VSD, PDA, pulmonary AV malformation, fistula, hepatopulmonary syndrome, they all will cause mixing of the blood here at the defect level. So, if the right side of blood will be mixed here, the oxygenator will be mixed with the oxygenated blood, causing hypoxia. Okay. And sometimes it is also happen in the physiological shunting, like blood pass through the non-ventilated alveoli, for example, pneumonia, atelectasis and ARDS. For example, this alveoli is damaged because of pneumonia, okay, and this part is not ventilating properly. So what will happen? The blood passing through this alveoli will be poorly oxygenated, and this poorly oxygenated blood will be again going to your systemic circulation, and also it will mix with the oxygenated blood that is coming from the well ventilated alveoli, causing ultimately decreased oxygenation, okay, because this part is well oxygenated, but the part of the blood that is coming from the poorly ventilated alveoli because of a disease condition is not properly oxygenated. So ultimately if both of them will be mixed, they will cause decreased oxygenation, and ultimately this is called a physiological shunt, and this shunt will improve once this disease condition like pneumonia, atelectasis, ARDS is improving. For example, if patient is admitted in our ward with large pneumonia, sometimes they are admitted and they also require initial oxygen therapy, but as we start treating the patient, their oxygenation improves and their pneumonia gets better. So as soon as their pneumonia gets better, lungs open up, alveoli becomes clean and clear after certain time of treatment, and they also take part in ventilation. So in that situation, this shunt improves, and ultimately oxygen supply, oxygen requirement of the patient decreases, and later on sometime we also stop the oxygen because patient is no longer requiring oxygen because the disease pathology is improving here, okay. So that is called physiological shunting, and this is anatomical shunt. Here we need a surgical correction, we have to close this shunt. We do many different kind of operations to close it shunt, okay. Now another mechanism is impaired diffusion of oxygen or diffusion limitation. What happens? Because there is a problem at the alveolar capillary membrane, that is this part, this alveoli and this is a capillary. So this membrane is normally diffusion occurs through this membrane, but in certain disease conditions this membrane gets thickened. Here you can see this membrane is thickened. Now this thickened membrane will cause a barrier to the gas transfer. So in that situation, the blood will have a difficult path to cross this barrier, and ultimately the oxygenation and also CO2 washout will be hampered in this situation. So this is seen in a disease called pulmonary fibrosis, okay, and this physiology is called diffusion limitation. That may be due to decrease in the lung surface area for diffusion, could be inflammation, fibrosis of the alveolar capillary membrane, low oxygen tension, and because of there is a extremely short transit time, okay. So this can lead to your diffusion limitation. So to conclude, what are the types of hypoxia? Types of hypoxia are, if you say, that is first is hypoxic, when there is a decreased oxygen tension, that is seen in high altitude, hyperventilation, VQ mismatch, and anemic hypoxia. Anemic hypoxia means there is a decrease of carrying capacity. If the patient hemoglobin is 6 or 7 gram, so hemoglobin is not in the enough amount to the carry oxygen, that we call anemic hypoxia, and it's seen as anemia in case of blood loss or carbon monoxide poisoning also. Stagnant hypoxia means there is a decreased perfusion. In case of heart failure, heart is not able to send the enough blood to the tissues, and that will cause hypoxia also. It is seen in shock and ischemia. Histotoxic, it is a typical of cellular hypoxia where everything is all right, but oxygen content is okay, and circulation to the distal part is also well maintained, but the tissue are not able to utilize that oxygen because of toxicity. It is specifically seen in cyanide toxicity or in some other metabolic poisons, and that is it characterized by shifting of oxygen hemoglobin curve. So what happens? Oxygen delivery to the tissue is all right, but the tissues are not able to utilize that oxygen because of this poisoning, cyanide poisoning. So this is called histotoxic hypoxia. All right. So this is to better to understand hypoxia, and in the subsequent lecture we will understand the cause of hypoxia and hypercarbia in the OAD. So by now we know that the cause of hypoxia in obstructive airway disease in COPD and bronchial asthma are airway obstruction and VQ mismatch. So this is airway obstruction and VQ mismatch is the main cause of hypoxia in obstructive airway disease. Alright, so we have understand to this much. Now coming to pathophysiology of CO2 production, we all know that CO2 is carbon dioxide, is a product of intercellularly, is a part of aerobic respiration, and ATP is generated, and CO2 is a waste product of its production, that is glucose is metabolized and 6 CO2, 6 H2 plus heat is generated. We all know this, that CO2 is produced as a part of metabolic process. Now, what is the pathophysiology of hypercarbia and hypercapnia and CO2, that is increased CO2 in the obstructive airway disease? Is this line is very important, that is structural abnormality in the airway, alveoli and pulmonary circulation in the COPD patient alters the normal VQ distributions. Because COPD, bronchial asthma, there is a changes in the airway or alveoli and pulmonary circulation, okay, and this leads to the alteration in the VQ distribution. So, this VQ mismatch is the main mechanism of abnormal gas exchange resulting in the hypoxia with or without hypercarbia. As we all know that if there is a VQ mismatch, because the ventilation and perfusion are not matched, that can cause hypoxia and hypercarbia also in some situations, or sometimes PCO2 level may be normal, okay. Apart from this, two important mechanisms that contribute to the hypercapnic respiratory failure, that is insufficient respiratory drive and defective ventilatory pump. So, these two things can contribute, but this is the main mechanism, that is VQ mismatch, and that happens because there is a structural abnormality in the airway, alveoli and pulmonary circulation, okay. Here we can see the cause of hypercapnic respiratory failure, that is called type 2 respiratory failure, seen in COPD, severe asthma, drug overdose, CNS injury, primary muscle disorder, neuromuscular junction disorder, anatomical chest deformity, kyphoscoliosis, flail chest, and in obesity hypoventilation syndrome. So, this is the, we should remember that VQ mismatch is the main mechanism of hypoxia with or without hypercarbia in obstructive airway disease patient. Now, coming to the indications of oxygen therapy, we all know that oxygen is important, and it is oxygen is important for the survival of the life. So, oxygen is, we know that it is rarely indicated for any other reason except from hypoxemia. Hypoxemia is a condition where we give oxygen, but in there are certain conditions also we can use oxygen as a treatment part, but mainly it is used for hypoxemia, okay. Oxygen can be given in the high or low concentration in all the conditions associated with the hypoxemia that we give to the patients. So, these are the indications for oxygen therapy like lower respiratory tract infection, upper airway obstruction, severe asthma, birth asphyxia, respiratory distress syndrome, severe sepsis, heart failure and so forth. Other indications can also be there if the patient has increased work of breathing, myocardial oxygen demand sometime, pulmonary hypertension, and hyperbaric therapy sometime we give in case of decompression sickness, gas embolism, gas gangrene or carbon monoxide poisoning, and sometimes the anemic hypoxia also. So, this is the list for oxygen therapy where we use in the medical conditions. Now, coming to long term oxygen therapy, some patients require long term oxygen therapy at the home. Here we can see the oxygen concentrator, the patient is using oxygen with oxygen concentrator with a nasal probe, and we can see the pulse oximetry where we measure the oxygen saturation and heart rate, okay. So, what are the indications of long term oxygen therapy? One is COPD, interstitial lung disease, pulmonary hypertension, cystic fibrosis and advanced cardiac failure. So, these are the certain disease conditions when we prescribe patient to the home oxygen therapy. In COPD, LTOT is indicated for the patient of COPD when the resting PO2 is 55 or saturation is 88% or less while being at rest in stable condition, and if resting PO2 is 59 mmHg or SaO2 saturation is 89% or less if there is evidence of core pulmonary, right heart failure or polycythemia. So, these are the conditions when we prescribe home oxygen therapy for the COPD patient. PaO2 we calculate by ABG. We do ABG patient, we do ABG for COPD patient, and we calculate, we see then ABG PaO2, that is partial pressure of oxygen in the ABG sample, all right. So, it has been shown that LTO2 may improve patient quality of life, depression, cognitive function, exercise capacity and hospital administration rate if prescribed appropriately in a selected patients. So, to conclude, we know that oxygen is life, hypoxia is a serious medical condition. Understand the mechanism of hypoxia in this condition gives insight to treat. We have to understand the mechanism of hypoxia in this condition, and then you can treat the patient, okay. And hypoxia in many conditions is treated with supplemental oxygen. Oxygen can also be prescribed in hospital as well as in the home in certain medical condition we have just seen. So, this is to conclude. Thank you so much for watching and see you all in the next video.